Hello students, I'm Aida Aliyeva from Pathophysiology department. The topic of lecture today is Pathophysiology of endocrine system. Firstly, about the general reasons, general mechanisms of the disorders of the endocrine system. We divided in these three groups. The first is disturbances of the central regulation of the glands. And it may be connected with dysfunction hypothalamus, and it may be connected with the disturbances of the hypophysis, that's the pituitary gland. And the pathological processes the occurring within the glands and extra-glandular change. These last two we may join as a peripheral disorders. Peripheral disorders mean the pathological processes in the gland and extra-glandular pathology. Now, which disorders may occur in the central regulatory mechanisms of endocrine glands? You see here the slide shows us the central regulation of the endocrine glands, and it carried out by the nerves, neuroendocrine, endocrine, and non-endocrine mechanisms. By these four mechanisms. The nervous system can affect the activity of glands by changing the perfusion or directly changing the activity of the functional elements of the endocrine gland. This mechanism called the pure nervous regulation. And the glands regulated by this way include the adrenal medulla, neurosecretory nuclei of the hypothalamus and the pineal gland and other. The next mechanism, neuroendocrine regulation. What does it mean? This type of regulation is carried out by hypothalamus. There are the neuroendocrine nuclei in the hypothalamus, and the neuroendocrine cells of the hypothalamus receive impulses from the brain cortex, limbic system, reticular formation, medulla oblongata, and spinal cord. And then neuroendocrine cells synthesis and secrete releasing factors. These factors stimulate or inhibit the synthesis of the tropic hormones in the hypophysis, in the pituitary gland. Stimulating factors are called liberins, and inhibitory factors are called the statins. The third regulation is the endocrine regulation. Endocrine regulation means the effect of the one endocrine gland hormone on the activity of another endocrine gland. For example, pituitary hormones, pituitary-trop hormones, change the activity of the peripheral endocrine glands. For example, pituitary thyrotropic hormone regulates the activity of the thyroid gland. The adrenal corticotropic hormone from the pituitary gland they regulate the function of the adrenal gland and etc. And in non-endocrine regulation, the activity of glands is regulated not by hormones but by the metabolites or ions in the blood. For example, synthesis and secretion of insulin and glucagon depends on the concentration of glucose in the blood. The secretion of aldosterone, the hormone of the adrenal gland, the secretion of this hormone depends on the concentration of potassium and the sodium ions, and the secretion of the parathyroid hormone depends on the concentration of the calcium ions in the blood. The central regulation of endocrine glands is realized by the transhypophyseal and parahypophyseal pathways. Transhypophyseal way means regulation of peripheral glands by pituitary gland, and parahypophyseal means without it. The thyroid gland, adrenal cortex, sex glands are regulated by the pituitary by transhypophyseal way. And this regulation forms hypothalamic pituitary peripheral endocrine system. Transhypophyseal regulation is implemented according to the principle of direct mechanism and feedback mechanism. Firstly, about the direct mechanism. According to the direct mechanism, under the influence of impulses from the cerebral nervous system, central nervous system, the neuroendocrine cells of the hypothalamus secrete the releasing hormones. In response to the action of releasing hormones, the corresponding tropic hormones are secreted in the adrenal hypophysis, in this part of the pituitary gland. And the influence of tropic hormones, effector hormones are formed in the peripheral glands. Pathologies of the endocrine system as a result of the direct principles are associated with a change in the synthesis and secretion of releasing, tropic and effector hormones. And next slide will explain you the mechanism of the feedback mechanism. The principle of the feedback mechanism is that a regulating parameter has an opposite effect on the activity of its regulator. For example, increasing of the thyroxine in the blood causes decreasing of the thyroleberine and thyrotropic hormones from the hypothalamus and adrenal hypophysis accordingly. And conversely, a decrease in this hormone in the blood causes increasing of the synthesis of thyroleberine and thyroid stimulating hormone, or thyrotropic hormones rather say. To assess the function of glands in the transhypophyseal regulation, it's important to determine the concentration of the tropic hormones in the blood. This allows to determine the localization of the pathological process. For example, in hypothyroidism, an increase in the thyroid-stimulating hormone level in the blood indicates the presence of the pathology in the thyroid gland itself, and a decrease in the thyroid-stimulating hormone content indicates that the pathological process is associated with the pituitary or the gland or hypothalamus. Feedback mechanism must be taken into account during hormonal therapy, using in prolonged corticosteroid therapy, for example. The using of this hormonal therapy, the synthesis of the corticoleberine and adrenocorticotropic hormone decreases. This leads by feedback mechanism. This leads to the hyperfunction and atrophy of the adrenal cortex, and therefore sudden cessation of prolonged corticosteroid therapy may lead to the withdrawal syndrome or cessation syndrome, which manifests as an acute insufficiency of adrenal cortex. This slide demonstrates you parahypophyseal regulation. Parahypophyseal regulation refers to the regulation of endocrine glands without participation of the pituitary gland. The function of the parathyroid glands, Langerhans islets of the pancreas, and the adrenal medulla regulates by this way, by parathyroid pathway. And as you see here, the function of the parathyroid gland regulates by concentration of the calcium in blood. The blood concentration of glucose regulates the synthesis and secretion of the insulin. Endocrinopathies connected with the pathological process in the endocrine gland are characterized by their hyperfunction or hypofunction. And usually endocrine hyperfunction are caused by the tumor of glands, which called adenomas, processing the secretory activity, whereas hypofunction may be as a result from the various lesions of the glands. For example, inflammation, allergy, removal of gland by the surgery, and even genetic disturbance in the synthesis of the hormone. And it should be noted that some tumors, for example, the tumor developing from the chromophobic cells of the pituitary gland, don't produce hormone. They compress the tissue and cause atrophy in the normal cells of the gland, and it results in its hypofunction. But frequently, tumors of endocrine glands synthesize the hormone of this gland and cause hyperfunction of the gland. For instance, eosinophilic adenoma of hypophysis, pituitary gland, produces a large amount of the somatotropic hormone, and this causes giantism or acromegaly. The adenoma of the pancreatic island, insulinoma, for example, is accompanied by hyperinsulinism, which results in the decreased blood sugar and hypoglycemia develops. The endocrine gland, as well as another tissue of the organism, may be affected by inflammatory process and infection diseases. Tuberculosis causes necrosis of the glandular tissue. For example, syphilis results in the syphilitic gamma granuloma. In thyroid, parathyroid, sexual glands, adrenal cortex, the pathological process connected with the autoallergic mechanism are observed. For instance, in Hashimoto diseases, it's autoimmune thyroiditis or lymphatic goiter. And moreover, the genetic disorders in the synthesis of hormones are frequent in the pathology of the sexual glands. Through hereditary defects may be observed also in the thyroid gland and the adrenal cortex. For instance, cretinism may be connected with hereditary deficiency of enzymes participation in the synthesis of thyroxine. Extra-glandular pathology. The factors which influence hormones out of the glands, extra-glandular pathology, that's after secretion into the blood may increase or decrease their activity. These states manifest themselves clinically as hyperfunction of the gland or hypofunction of the gland. So extraglandular or peripheral mechanisms depend on the further fate of the hormones in the blood. The first is change of the hormone's conjugation with plasma protein. This results in increase the hyperfunction of the free form of the hormone or decrease hypofunction of the free form of the hormones in the blood. The second is disturbance of the cytoreception. Blockage of the hormonal receptor is frequent type of the endocrinopathies. Blood content of the hormone is normal or even higher, whereas symptoms of its hypersecretion are observed, and action of the exogenous hormone is also weak. Breakdown of the hormone by enzymes. For instance, insulin maybe breaks down under influence of the insulinase. The next is decrease of the activity of hormone in the blood. It may result from synthesis of autoantibodies against certain hormone or change in its molecular structure, active center of the molecule. For instance, there are hypophyseal dwarfism or nanism with high blood content of the somatotropic hormone, which cannot influence the growth, whereas administration of the exogenous somatotropic hormones stimulate the growth. And the next is disturbance in the permissive effect of steroid hormones. Decreased blood content of glucocorticoids weakens action of the hormonal the hormones of the distant effect. For example, the adrenaline, somatotropic hormone, the insulin, the glucagon, and other. In the next slides, we will discuss the action of the distant and direct hormones. And at last, the weak metabolism of hormones. This may result from the disturbed hepatic function, the disturbed disorders of the liver. Some hormones they accumulate in the organism and cause corresponding change. For example, weakness of the metabolism of the aldosterone in the liver, for example, during cirrhosis, accelerates the development of the ascites and edema. In hepatic insufficiency of men, inactivation of the estradiol is slowed down, and this caused the hypersecretion of the gonadotropic hormone by feedback mechanism. The function of the testicles is also weakened and impotency comes into being. As the initial stage of the endocrinopathies connected with the extraglandular peripheral mechanism, the function of the corresponding gland is normal, but then under the influence of the feedback mechanism, the changes occur in the blood, in the gland. As As we have noted, the hormones have a distant and direct effect on the target cells. Hormones of the distant action include hormones of the protein peptide origin, for example, catecholamines. These hormones bind with the receptors on the surface of the target cell, activate the membrane-bound enzyme adenylate cyclase, resulting in the increased cyclic adenosine monophosphate in the cells, and cyclic adenosine monophosphate activating protein kinase phosphorylates protein substrates. Thus, due to chain reactions, intracellular metabolic processes change. For example, by this way, catecholamines regulate the intensity of the glycogenolysis. Direct hormones include thyroid hormones and steroid hormones. Having penetrated through the cell membrane, they bind to the cytoplasm with a specific receptor protein. The resulting complex penetrating into the nucleus binds to the corresponding gene, stimulates or inhibits the expression of this gene. This increases or decreases the synthesis of the corresponding enzyme. For example, steroid hormones increase the expression of genes encoding anti-inflammatory proteins. This is called lipocortin effect. And the expression of genes encoding the synthesis of pro-inflammatory cytokines reduced, as well as interleukin-1, interleukin-D6, colony-stimulating factor, the tumor necrosis factor, all they reduce. Pathology of hypophysis, pituitary gland. As you know, the function of pituitary gland regulates by hypothalamus releasing hormones. And there are anterior and middle parts, or adenohypophysis and neurohypophysis are distinguished in the pituitary gland. You see here the hormones of the corresponding parts. Somatotropic hormones, the growth hormone, is secreted from the eosinophilic cells of the adenohypophysis. The adenocorticotropic hormone is secreted from the basophilic cells of the adenohypophysis. Then thyrotropic hormone or thyroid stimulating hormone is also secreted from the basophilic cells of the adenohypophysis. Then the gonadotropic hormones. The gonadotropic hormones include the follicle, the stimulating hormone, luteinizing hormone, and prolactin. They regulate the function of the sexual glands, and melanocyte-stimulating hormones, the hormone of the middle part of the pituitary gland. And the hormones of the neurohypophysis are oxytocin and the vasopressin, antidiuretic hormone. These hormones are synthesized in the neurosecretory cells of the hypothalamus and then accumulates and secretes to the blood from pituitary gland. Hyperfunction of pituitary gland, which is called hyperpituitarism, that is oversecretion of the one or more of the pituitary hormones, and may be due to disease of the anterior pituitary, posterior pituitary, or the hypothalamus. Hyperfunction of the pituitary, anterior pituitary, is due to development of the hormone-secreting pituitary adenomas, it's benign tumors, or rarely the carcinomas, the malignant tumors of the pituitary gland. Hypersecretion of the growth hormone results in giantism and acromegaly. Both these clinical syndromes result from sustained excess of the somatotropic hormone, most commonly by somatotropin-secreting adenoma. And rapid tissue growth in giantism and acromegaly is connected with the metabolic change also. Somatotropin accelerates biosynthesis of the proteins and inhibits their catabolism. Its anabolic action depends on the content of the insulin and glucocorticoids in the blood. Growth hormone accelerates the process of the lipolysis in fat tissue and formation of the ketonic bodies. In giantism and acromegaly, carbohydrate metabolism is also disturbed. Acromegaly is frequently accompanied by diabetes mellitus. So in this slide, you can compare the health of the body during giantism and nanism, pituitary dwarfism. Hypersecretion of the somatotropin prior of the epiphyseal closure, ossification of the epiphyseal cartilage lead to the giantism. So giantism occurs in prepubertal boys and girls. The main clinical feature of giantism is excessive growth of the child, enlargement as well as the thickening of the bones resulting in the considerable increase in height and enlarged thoracic cage. The giants are very tall. The height of the body is more than 2 meters in height. Acromegaly rises as a result of hypersecretion of the somatotropic hormone in adults following cessation of the bone growth. It's more common than giantism. Acromegaly is characterized by enlargement of hands, you see here, the feet, tongue, and lips, thickening of the skin, and prominent supraorbital ridges and more prominent lower jaw. For example, it's called prognatism and kyphosis. The volume of the internal organs also increases. It's called splachnomegaly. Sometimes thyroid-stimulating hormone excess resulting in the thyrotoxicosis and gonadotropin insufficiency causing amenorrhea in the females and impotence in the males may be observed too. Hypersecretion of the adrenocorticotropic hormone is a main pathogenic factor of Ising-Cushing syndrome, you see here. Ising-Cushing disease is pituitary-dependent Cushing syndrome, and there are four major the etiological types, forms of Cushing syndrome we know. The first form is pituitary Cushing syndrome or Ising-Cushing syndrome. This is caused by excessive secretion of the adrenocorticotropic hormone due to corticosteroid, the secreting adenomas. The adrenocorticotropic hormone accelerates the synthesis of the glucocorticoids in the adrenal cortex and causes secondary hypercorticosteroidism. This disease is characterized by adiposis of the face, this is called moon face, neck and trunk, but not limbs, and elevated blood pressure, increased erythrocyte count, hypogenitalism, phenomena of the masculinization in women, and hyperglycemia and glucoseuria. The organism's resistance against infections is decreased. All these were the signs, the main manifestation of the Ising-Cushing diseases. The next form is Cushing syndrome, is adrenal Cushing syndrome. And here we observe the hypersecretion of the glucocorticoids from adrenal cortex of the adrenal gland. It occurs because of the adenomas, glucosteroma, arising, developed in the adrenal cortex. The third form is ectopic Cushing syndrome, has an origin in ectopic adrenocorticotropic hormone elaboration by non-endocrine tumors. For example, during lung cancer, malignant tumor, pancreatic tumors, they may secrete, produce this hormone. And the plasma adrenocorticotropic hormone level is high and cortisol secretion is not suppressed by dexamethasone administration here. And the fourth form of the Cushing syndrome is iatrogenic Cushing syndrome, may result from the prolonged administration of the high doses of the glucocorticoids during hormonal therapy. For example, after organ transplantation in autoimmune diseases, and these causes are generally associated with bilateral adrenocortical insufficiency. Hypersecretion of thyrotropic hormone causes hyperfunction of thyroid gland. Hyperthyroidism and the thyrotoxicosis develop. Tyrotropin increases the amount of the acid mucopolysaccharides in the skin, muscles, and behind the eyeballs. This is connected with the increase of number of muscles in which acid mucopolysaccharides are synthesized. Accumulation of the acid mucopolysaccharides behind eyeball causes exophthalmos. Hypersecretion of the gonadotropic hormones, which include follicle-stimulating hormone and luteinizing hormone, result in the hyperfunction of sexual glands. In childhood, this causes premature puberty, and frequently hypophyseal hypergonadism is of the familiar character. Hyperprolactinemia is excessive production of the prolactin, most commonly by prolactinoma, that's the prolactin secreting the adenoma. This includes Chiari-Fommel and the Forbes-Albright syndromes. Both of these syndromes are accompanied by amenorrhea, which means the stop of the menstruation, and galactorrhea. In Chiari-Fommel syndrome, these changes appear after pregnancy, after child delivery, but in Forbes-Albright syndrome, amenorrhea and galactorrhea characterized by infertility and is not related to with pregnancy. In male, it may cause impotence or reduced libido. These features result either from associated inhibition of the gonadotropic secretion. In hypopituitarism, there is usually deficiency of one or more of the pituitary hormones, affecting either anterior pituitary or posterior pituitary and hypothalamus. The total anterior pituitary insufficiency is called panhypopituitarism. Its most common cause are the chromophobe adenoma, Sheehan syndrome, or Simon diseases. Pituitary insufficiency occurring due to ischemic pituitary necrosis is called Sheehan syndrome, whereas occurrence of the similar process without preceding pregnancy, as well as its occurrence in the males, is termed Simon diseases. Sheehan syndrome results from spasm of hypophyseal blood vessels during hemorrhage after labor of the abortion, as well as sepsis, septic embolism, also developing after labor of abortion. The clinical manifestation of Sheehan syndrome include failure of the lactation following delivery due to deficiency of prolactin, amenorrhea, and loss of the libido. Deficiency of thyroid stimulating hormone and adrenocorticotropic hormone may result in the hypothyroidism and adrenocortical insufficiency. Both Sheehan syndrome and Simon syndrome, this disease, the symptoms of the panhypopituitarism appear when 90–95% of the adenohypophyseal cells pituitary cells are distracted. Synthesis hormones is sharply decreased, and general weakness, anorexia, that's loss of the appetite, atrophy of the organs and tissues, decreased resistance of the organs and tissues, decreased resistance of organism against the infection diseases, and disturbances in the sexual functions and functions of the central nervous system, hypophyseal cachexia are observed in both these syndromes. And partial hypopituitarism includes the deficiency of the separate hormone of the adenohypophysis. Severe deficiency of the growth hormone in children before growth is completed and result in the retarded growth and pituitary dwarfism or the nanism. Frequently, it's a result of an inherited autosomal recessive disorder, but may also result from pituitary adenoma or infarction and trauma of the pituitary gland. The clinical feature of the inherited cases of the pituitary dwarfism, which appear after 1 year of age, include proportionate retardation in growth of bones, normal mental state for age, poorly developed genitalia, and episodes of the hypoglycemia. The weight of adult male dwarfs is less than 130 centimeters, and that of female dwarfs less than 120 centimeters. Predisposition to the obesity is observed also. The hypersecretion of the adrenocorticotropic hormone causes the secondary weakness of the adrenal cortex function. Secretion of the glucocorticoids is changed more markedly, which is called this pathology called Addison syndrome. Addison syndrome must be distinguished from differentiated from Addison diseases. Addison disease is a primary insufficiency of the adrenal cortex, in which pigmentation of the inadrenal syndrome in adrenal Addison's diseases, we observe the pigmentation of the skin. Hence, that's why these diseases are called the bronze diseases, because the primary hyperfunction of the adrenal cortex causes the hypersecretion of the adrenocorticotropic hormone, and by the feedback mechanism, some products of the hydrolysis of which possess melanotropic action. And insufficiency of the thyrotropic hormone causes hyperfunction of the thyroid gland. Hypersecretion of gonadotropic hormones before the period of the puberty causes infantilism, which is frequently accompanied by growth inhibition. Usually secondary sexual characteristics don't develop, and development of sexual organs is delayed. In hypophyseal hypogenitalism, which develops after puberty, in men in impotency, azoospermia, hypospermia are observed. Frequently, sexual glands are atrophied, and gradually some secondary sexual characteristics disappear. Change in the person's appearance, the baldness, premature senility, obesity occur. In women, early cessation of menstruation, spontaneous abortion and infertility, atrophy of mammary glands, premature senility, and predisposition to the obesity are observed. One of the frequent variants of the versions of the gonadotropic hormones hypersecretion is adipose-genital dystrophy, which results from the lesion of the hypothalamo-hypophyseal system. It may occur during toxoplasmosis, birth injury, tuberculosis, syphilis, cerebral injury, tumors of the hypothalamus, and the thrombosis, embolism of cerebral vessels. And the first symptoms of the adipose-genital dystrophy are observed at the age of the 6-7 years in boys or 10-13 years in girls. And hyperorexia, the obesity, arrest of the development of genital organs, so stopping of the genital organs, change in the higher nervous the activity observed. In boys, obesity develops, which is characteristic of female body structure, increases subcutaneous fat in neck, arms, chest, abdomen, pelvis, and buttocks, and hairs on the face and body don't develop. Antidiuretic hormone hypersecretion or hyposecretion. Hypersecretion of antidiuretic hormone causes oliguria and accumulation of the water in the organism. Secretion of the antidiuretic hormone may be increased by a reflex way as a result of the pain or the emotional strain. Nicotine and acetylcholine also increase its secretion. And really pulmonary diseases, tuberculosis, lung abscess, pneumonia may cause overproduction of the antidiuretic hormone. Inappropriate release of the antidiuretic hormone occurs most often in paraneoplastic syndromes. For instance, in small cellular carcinoma of the lungs, carcinoma of the pancreas, lymphoma, and thymoma. Rare lesion of the hypothalamus, trauma, hemorrhage, then toxic infection, allergic physical factors cause disease. The main pathogenic factor of which is antidiuretic hormone hypersecretion, which cause Parkinson syndrome. The significant clinical syndrome due to hyposecretion of the antidiuretic hormone is diabetes insipidus. The reasons may be inflammatory or neoplastic lesion of the narrow hypophysis due to surgery, radiation, and by any idiopathic case. The main feature of the diabetes insipidus are polyuria excretion of or a very large amount polyuria. Polyuria means excretion of a very large amount of the urine, and this is called polydipsia. Pathologies of adrenal gland include hyper or hypofunction of the adrenal cortex, that's called hypercorticosteroidism, and hypocorticosteroidism. Consequently, hyper and hypofunction of the adrenal medulla are observed relatively rare. And in hypercorticosteroidism, the secretion of the one or all hormones of the adrenal cortex may be increased. The most common are hypercortisolism, aldosteronism, and adrenogenital syndrome. The main cause of primary glandular hyperplasia is most often the tumors that develop in the gland itself. For example, glucosteroma, tumor secreting glucocorticoids, aldosteroma, tumor secreting aldosterone, and androsteroma, tumor secreting androgens, corticosteromas, tumor secreting estrogens, and mixed tumors. Hypercortisolism is a complex of change resulting from the increased secretion of cortisol in the adrenal cortex and is called Cushing syndrome. You see here 4 forms of Cushing syndrome: central, secondary, and peripheral primary, ectopic, and iatrogenic origin. Hypercortisolism of the central origin occurs as a result of change in the activity of hypothalamus or pituitary gland, and peripheral hypercortisolism occurs as a result of change in the gland or extra-glandular increase in hormone activity. Some tumors, for example, small cellular cancer of lung, synthesize adrenocorticotropic hormone and cause ectopic hypercortisolism. When glucocorticoids are used for therapeutic purpose, iatrogenic hypercortisolism may occur. In adrenal Cushing syndrome, in contrast to pituitary Cushing syndrome, as a result of increased secretion of glucocorticoids, the secretion of the corticoliberin and adrenocorticotropic hormone decreases by feedback mechanism. However, in both pathologies, an increase in the content of glucocorticoids leads to the disturbance of the carbohydrate, protein, fat, water electrolyte, and other types of metabolism. As a response to hyperglycemia, insulin secretion increases, then pancreas beta cells, as a result of excessive tension, weaken and depleted. In this case, insulin secretion decreases and steroid diabetes develops. In patients with Cushing syndrome, a large amount of fat accumulates in the lateral parts of abdomen, in the chest and face. This is called moon phase, and striae are formed. Blood pressure rises due to an increase in the total blood volume and an increase in the sensitivity of the vascular wall to catecholamines. The effect of the cortisol on hematopoiesis is different. It accelerates erythropoiesis and the formation of the neutrophils, causes neutrophilia, but delaying of the formation of the lymphocytes and eosinophils are also characteristic to this pathology. Hyperaldosteronism develops with tumors of the glomerular zone of the adrenal gland. This is called primary hyperaldosteronism or Cone syndrome. The occurrence of secondary hyperaldosteronism is associated with extra-adrenal pathology, for example, due to the activation of renin-angiotensin-aldosterone system. Primary aldosteronism, hyperaldosteronism, is manifested mainly by change in the cardiovascular system, kidneys, and neuromuscular excitability. Excessive secretion of aldosterone leads to the disturbance of the water electrolyte balance. Due to acceleration of the sodium reabsorption and potassium secretion in the kidneys, hypernatremia and hypokalemia occur. Hypokalemia leads to the neuromuscular weakness, even to the paralysis. At the onset of the cone diseases, daily diuresis decreases, but then the disease progresses, the potassium content inside the cell decreases excessively, and sensitivity of epithelial cells to the antidiuretic hormone in the renal tubulus decreases, the polyuria is observed. Therefore, in Cone syndrome, edema doesn't develop. The cause of development of the secondary hyperaldosteronism is a pathology that leads to the decrease in blood volume or a decrease in the blood pressure, heart failure, nephrosis, glomerulonephritis, liver cirrhosis. This secondly leads to the activation of the renin-angiotensin system and secondly to an increase of aldosterone. And unlike Cone syndrome, in secondary hyperaldosteronism, a high content of renin and angiotensin in the blood is observed and edema develops. Adrenogenital dystrophy, this syndrome develops in hereditary or acquired insufficiency of enzymes involved in the synthesis of cortisol. This pathology is transmitted, inherited by autosomal recessive way. There are insufficiency of two enzymes that lead to the cortisol deficiency, 21 hydroxylase and 11 beta hydroxylase. In the 21 hydroxylase deficiency, due to cortisol deficiency, the synthesis of corticoliberin in the hypothalamus and adrenocorticotropic hormone in the pituitary gland increase by feedback mechanism. Adrenocorticotropic hormone stimulates the synthesis of steroids to the point of the blockage. But due to the fact that cortisol doesn't form because of the enzyme insufficiency, this stimulation is aimed at the formation of androgens. Their content in the blood increases. Hypersecretion of androgens by the feedback mechanism reduces the secretion of gonadotropic hormones, which in turn leads to the hyperfunction of the gonads. As a result, in both girls and boys, the sex glands goes into the atrophy. And in the deficiency of the next, the enzyme, deficiency of the beta 11 beta hydroxylase, cortisol synthesis impaired also. In this case, a large amount of the 11 desoxycorticosterol the forms, which have the action of the similar to mineral corticoids. And moreover, due to the fact that cortisol is absent by feedback mechanism, the synthesis of the adrenocorticotropic hormone also increases. And adrenocorticotropic hormone stimulates the synthesis of the androgens. Hypersecretion of sex hormones belonging to the other sex lead to the development of the heterosexual form of the adrenogenital syndrome, and increases secretion of sex hormones belonging to the same sex or their premature secretion lead to the development of the isosexual form of the adrenogenital syndrome. Hyperfunction of the adrenal cortex. Insufficiency of the one of the hormones of the adrenal cortex is called partial. Insufficiency of all hormones is called the total corticosteroid insufficiency. Over the course of the hypocorticosteroidism is acute and chronic. By origin, central and peripheral forms are distinguished. In people with acute hypocorticosteroidism, this called Waterhouse-Friderichsen syndrome, develops as a result of hemorrhagic adrenal infarction. The reason for this may be a meningococcal infection, the traumatic damage of the adrenal gland, adrenal vein thrombosis, and prolonged anticoagulant therapy. In these diseases, in connection with an acute dysfunction of the adrenal glands, collapse develops, the sharp decreasing of the blood pressure develops, which lead to the death of the patient. Addison disease is a chronic insufficiency of adrenal cortex. Because of insufficiency of corticosteroids by the feedback mechanism, here is the adrenocorticotropic hormone secretion from pituitary gland increase, in contrast to the other Addison syndrome. And increased adrenocorticotropic hormone leads to the hyperpigmentation of the skin. Associated with this symptom, Addison disease, also called the bronze diseases. In Addison disease, aldosterone deficiency is accompanied by a disturbance of water electrolyte balance. Sodium reabsorption in the renal tubules is weakened and it's excreted in the urine. Along with sodium, the body loses a large amount of the water, and polyuria becomes the cause of dehydration. Blood volume decreases, blood thickens, and arterial hypotension develops. At the same time, in case of aldosterone deficiency, potassium secretion in the renal tubule decreases and its content in the blood rises. Thus, hyponatremia and hyperkalemia occur. Hyperkalemia leads to an increase in sensitivity of epithelial cells of distal renal tubules to the antidiuretic hormone. As a result, water reabsorption is accelerates, diuresis is reduced, and oliguria occurs. Hyperfunction of the adrenal medulla is caused by tumor of the adrenal medulla. This is called pheochromocytoma. That's accompanied by hypersecretion of the catecholamines. You know, in the catecholamines, they synthesis in the medulla, adrenal medulla. These tumors are mainly benign. The disease is accompanied by disorders of the cardiovascular and nervous system. Blood pressure rises here in a paroxysmal form. And during crisis, blood pressure rises to 250 milliliter mercury and more. And this process lasts 30 minutes. Hypofunction of the adrenal medulla is considered the main pathogenic factor of arterial hypotension, arterial hypertony. This pathology is rare because there are other chromaffin cells located outside the adrenal medulla synthesize catecholamines. Hypofunction of the adrenal medulla is called Riley-Day syndrome, autosomal recessive hereditary diseases. In this disease, the conversion of the dopamine to norepinephrine is impaired as a result of relative or absolute insufficiency of dopamine beta hydroxylase enzyme. Pathology of the thyroid gland. Severe clinical forms of hyperthyroidism are called thyrotoxicosis. The main clinical manifestation of the thyrotoxicosis is diffuse toxis goiter. This is called Bazedov disease or Graves' diseases. Graves' disease is characterized by an increase in the size of the gland, exophthalmos, you see here, tachycardia, acceleration of the male metabolism, increased heart rate, heart activity, trembling of the fingers, tremors, increased mental irritability, and in rare cases, dermopathy, thickening of the skin in the pretibial region, and other signs. The pathogenic basis of the Graves' disease is the autoimmune process. In this case, antibodies against thyroid-stimulating hormone receptors are formed on the surface of the thyroid epithelial cells. And these antibodies stimulate the activity of thyroid gland, which lead to the hyperthyroidism. Hypofunction of the thyroid gland. As a result of congenital aplasia of the thyroid gland or hereditary insufficiency of the enzymes involved in the biosynthesis of the thyroid hormones, cretinism develops. And cretinism is characterized by decreasing of growth and disproportionate physique, short limbs, square shape and large head size, swelling of the face and a large tongue. The physique of the patient is disproportionate. The development of the sex glands in this patient the lags behind. In cretins, dementia and lack of the intelligence are observed. To prevent this change, thyroid hormones are prescribed to the patient from the first days of their life. One of the clinical forms of the hypothyroidism observed in adults is called myxedema, mucosal edema, resection of the greater part of the thyroid gland, taking high dose of the thyrostatic drugs, intense radiation therapy, iodine deficiency can cause myxedema. Patients with myxedema experience lethargy, inertness, decreased intelligence and decreased memory, slow and syllabic the speech, hair loss, the destruction of the nails and inhibition of all the metabolism into the organism. The main sign of this disease is edema. And the other form of the hyperfunction of the thyroid gland is endemic goiter. It's a special form of the hypothyroidism which is observed in areas where the water and soil there is a little iodine. The low iodine content reduces the secretion of the thyroid synthesis and secretion of this thyroid hormone. And according to the feedback mechanism, the thyroid stimulating hormone secretion in the pituitary gland is accelerated. And as a result, gland hyperplasia, hypertrophy develops. Due to this, the secretion of thyroid hormones increase slightly. And with prolonged, protracted iodine deficiency, the noted compensation mechanism cannot provide the secretion of the sufficient amount of the thyroid hormones, and hypothyroidism develops. The most common form of the thyroiditis is Hashimoto diseases. Like other autoimmune pathologies, Hashimoto disease has a hereditary predisposition, and this is associated with the HLA genes, the human leukocytic antigen genes. In Hashimoto disease, humoral and cellular the mechanism take place. In humoral mechanism, antibody dependent and complement dependent cytotoxicity, and in cellular type, cytotoxic and delayed hypersensitivity reaction may occur. The disease is triggered by infections or allergic damage to the thyroid gland. At the same time, glandular tissue undergoes destruction as a result of cellular immune responses. Cellular components, thyroid stimulating hormone receptor, thyroglobulin, thyroid peroxidase, and others pass into the blood, and autoantibodies are synthesized against thyroglobulin, thyroid peroxidase, and these thyroid stimulating hormone receptors. And autoantigens are not eliminated. Chronic inflammation develops. Granuloma, mononuclear infiltration, fibrosis occur in the glandular tissue. The size of the gland increases. The autoantibodies, antithyroglobulin, antithyroid peroxidase, and etc. with autoantigens increases the destruction of the glandular epithelium, the structure of the thyrocytes, and all this leads to the hypofunction of the thyroid gland. Hyperfunction of the parathyroid gland, hyperparathyroidism. This pathology occurs during hyperplasia and tumors of with the hormonal activity. Among pathologies accompanied by hyperparathyroidism, Recklinghausen disease is of great importance. This is a primary hyperparathyroidism. Here, as a result of the hypersecretion of the parathyroid hormone, bone tissue loses calcium, which causes osteoporosis. Bone tissue is replaced by fibrous tissue and softens. This is called osteomalacia. Patients often have the bone fractures here. Hypersecretion of parathyroid hormone reduces sensitivity of renal tubular epithelium to the action of the antidiuretic hormone, which lead to the polyuria and polydipsia. The excretion of calcium in the urine is accelerates, and as a result of deposition of the calcium salts in the renal tubules, the tubular epithelium cells calcify. This change becomes the cause of the development of the oliguria, and in severe cases it may cause the anuria and uremia. Hypersecretion of the parathyroid hormone accelerates the excretion of the phosphate from the kidneys, and as a result, the phosphate content in the blood decreases. This is called hypophosphatemia. As a result of the hypercalcemia, neuromuscular excitability decreases and muscle tone decreases. Hypofunction of the parathyroid gland, hypoparathyroidism. This develops as a result of damage to the gland or removal it during surgery. Hypocalcemia and hyperphosphatemia occur in this case. Against the background of hypocalcemia, neuromuscular irritability increases. Tetany attacks occur. Tonic and clonic convulsions periodically occur in this pathology, and there are changes in the functions of respiratory and cardiovascular systems. The motor function of the gastrointestinal tract is disturbed, and often pleurospasm and laryngospasm occur. Male genital hyperfunction, which is called hypergonadism, can be central and peripheral origin. Hypergonadism of the central origin develops during inflammation or tumors of the region of the great tubercle. Hypergonadism of peripheral origin develops in the tumors of the Leydig cells. If testosterone hypersecretion occurs in the prepubertal period, premature puberty occurs. The boys grow quickly, then due to premature ossification of the cartilage, growth stops, and muscle develop increase due to the anabolic effects of the androgens. And in hypergonadism of the central origin, due to synthesis of the androgens, the spermatogenesis process is also stimulated. In hypergonadism of the peripheral origin, when the Leydig cell tumor, androgen synthesis increases and spermatogenesis decreases. This is due to a decrease in the secretion of the gonadotropin in the pituitary gland by the feedback mechanism. Hypofunction of the male sexual glands, hypogonadism, can be of the central and peripheral origin also. In decrease of the hypothalamic pituitary system, hypogonadism is the central origin. At the same time, androgen hypersecretion occurs due to a decrease in the gonadotropin hormone. And signs of the hypogonadism of central origin appear after puberty. Hypogonadism of the peripheral origin may be congenital and acquired. The main forms of the congenital hypogonadism are observed in the aplasia of the gonads, injuries to the male genital glands, tuberculosis, syphilis, gonorrhea, or heat may lead to the primary acquired hypogonadism. And at last, about the female sexual glands, hyperfunction and hypofunction of the female sexual glands. Ovarian hyperfunction may be central and peripheral origin. Hyperfunction of ovarian of central origin develops in the meningitis, encephalitis, and tumor of brain. And the result of the hormonal imbalance depends on the age of patient and the main mechanisms for the development of the change. Increased ovarian function in the pre-puberty period leads to the premature puberty up to 9 years and the development of secondary sexual signs. Menstruation begins early. Estrogen hypersecretion leads to the prolonged menstruation with a severe blood loss and the increase of the progesterone secretion may lead to the delayed menstruation. The puberty of the female body occurs between 14 years, and delayed puberty is accompanied by lag in the development of the female genital organs, uterus, cervix, fallopian tubes, mammary glands, and disturbance of the puberty becomes a delay in the general physical development. This is called infantilism. Infantilism is associated with insufficiency of the pituitary functions. And so, in the pituitary gland, the secretion of not only gonadotropin but also other tropic hormones decreases. As a result, growth is delayed and hypofunction of thyroid gland and adrenal glands occur. Ovarian insufficiency can manifest itself as estrogen and progesterone deficiency, separately or together. If estrogen deficiency occurs before puberty, then the development of the female genital organs delayed, primary amenorrhea is observed. If estrogen deficiency occurs after end of the puberty, the genitals and mammary glands undergo atrophy and menstruation stops. The progesterone deficiency, the menstruation is accompanied by the severe bleeding during estrogen deficiency, and patients have the spontaneous abortion and infertility. Both estrogen and progesterone deficiency occurs in the women after ovarian ectomy. In this case, signs associated with the dysfunction of the vegetative nerve system, facial flushing, feeling of the heart, the tachycardia, insomnia, intense sweating, all they observed. The content of cholesterol and sometimes glucose rises, and these signs can be observed in women in menopause. And thank you for listening. Thanks a lot.